Welcome everyone to today's webinar on Earlier, Smarter, Better, Transforming Heart Failure Diagnosis with AI. We're thrilled to have you join us for what promises to be a robust and insightful discussion. We'll be starting our content in just a moment to allow our final attendees all to log on to the session. And as we're waiting, we can go ahead and go over a couple of housekeeping items and notes. For this session, I wanted to remind everyone we will be recording, and both the slides and recording will be available on DIME's website shortly after the webinar concludes. We ask that you do not transcribe this session. Finally, if you have any questions during the discussion, please type them into the chat box, and if we have time, we'd love to get to these with our panelists. And with that, we can jump in. I think we've allowed everyone a little bit of time to join us, so we can move into our content for today. First, I'll introduce myself. My name is Samantha McClanahan, and I'm a program lead for digital measures and diagnostics at the Digital Medicine Society, and I will be your moderator for today's discussion. The challenge of heart failure that we are here to discuss today is massive. It presents a significant and growing problem in our healthcare system. In the United States alone, nearly 6.7 million adults are living with the condition. As our panelists know very well, early and accurate diagnosis is paramount for the effective treatment, yet it remains a complex endeavor. Today, we'll explore how digital innovation and artificial intelligence are revolutionizing the space. We'll delve into the immense promise of AI in early detection, focusing on the complex use case of HFpEF. We'll also discuss the practical barriers to implementing these cutting-edge technologies and examine how we can build trust and evidence required to accelerate their adoption. Finally, we'll look ahead to the future, envisioning how AI will reshape cardiac care. To kick things off, we want to start with a visual challenge to our audience. Here are two echocardiogram scans. Take a look for a second. Can you spot which one indicates the presence of amyloidosis? This exercise highlights the complexities that AI are helping us navigate, and we'll circle back to answer this at the end of our panelist discussion, and we'll let them dive in a little bit more on the diagnoses here. And with that, let's meet our incredible panel of experts that'll be joining us today. They're at the forefront of the field, living and breathing these challenges and innovations every day, and they'll guide our discussion throughout the talk. So first, let us start with Dr. Curran.
Hi, thank you for having me. My name is Mike Curran. I am a non-invasive cardiologist. I practice at UPMC St. Margaret. I'm the section chief for cardiology at UPMC St. Margaret Hospital. And I also spend quite a bit of time as a clinical informatics physician implementing technology and softwares over the past decade or so here at UPMC. Thank you for having me today.
Thank you, Dr. Curran. Dr. Upton.
Thank you for having me, Samantha. I'm Ross. I'm founder, CEO, and chief scientific officer of Ultromics. I also co-chair the AI committee for HeartShare, which is an NIH program dedicated to finding novel phenotypes of heart failure. Prior to Ultromics, I was a PhD student in cardiovascular medicine at the University of Oxford. It's a pleasure to be here.
So glad to have you here. Dr. Strum.
Hi, everybody. Thank you so much for having me here today. It's a great discussion. I'm a non-invasive cardiologist, direct the Echo Lab at Beth or Deaconess Medical Center in Boston, Massachusetts, and an associate professor of medicine at Harvard Medical School. And most of my time I spend outside of the practicing clinical medicine, I spend thinking about how to better restructure care to improve value and to understand the appropriate use of imaging. And a lot of that, of course, overlaps with this area. Serve for the ACC and AAC on their AI guidance committees. Thank you.
Thanks, Dr. Strum. It's exciting to be in the room with all three of you today, the leading experts within the space and the advancements that you have, not only within heart failure, but also the care you provide to your patients. So really excited for our discussion. Want to kick off around kind of understanding the problem a little bit better. Want to get your perspective on where the foundational understanding is that our diverse audience might need to come into this conversation around heart failure and care.
Yeah, I can lead with that. So as you mentioned earlier, heart failure in general, which is the body's inability to be able to effectively pump or blood forward without it ultimately, pressures accruing and ultimately sort of fluid going into the lungs and people feeling quite ill. Happens in about 7 million Americans, and about half of those have what we call heart failure with preserved ejection fraction, which is when the heart function, the amount that's ejected in a single beat, is relatively preserved, is normal. But that being said, those people often have troubles filling their ventricle, and so they can't get enough blood out to meet the needs of the tissues, and ultimately their pressures in their heart and their lungs can be high and cause them to feel just as short of breath. And while we have much better therapies nowadays for heart failure with reduced ejection fraction, and we have gotten a whole lot better at getting to treat people's heart attacks earlier so that they don't develop as much dysfunctional heart tissue, we have trouble recognizing and treating heart failure with preserved ejection fraction, which continues to be an increasing burden to our society. As we know, increased rates of diabetes and obesity and other risk factors increase in the population. That also makes it more likely that people may survive heart attacks, but may ultimately be left with a very stiff or non-compliant left ventricle, and that is an extremely large clinical problem.
And Jordan, to add to that, you talked about preserved versus reduced ejection fraction, and one of the big challenges in making this diagnosis is the symptoms can be very nonspecific or be attributed to many different disease processes. So you have to listen to a patient and hear their story. And often one of the diagnostic tests that we get in addition to some routine blood work is maybe a chest X-ray, but we often, if we're suspecting heart failure, we get an echocardiogram. At least as cardiologists, that's kind of a mainstay of our confirming a diagnosis. It's easier to make a diagnosis of heart failure with reduced ejection fraction because you get the echo, you suspect heart failure, and the ejection fraction is reduced. It's 20% or 35%, and that's really oftentimes confirming your diagnosis. But when you're suspecting HFpEF and or preserved ejection fraction, and you get that echo back, you still don't have a 100% definitive diagnosis, and you still have to think about those other possible etiologies of symptoms. Is it lung disease? Is it related to obesity? Is it related to venous insufficiency or something else? So it's much more challenging to feel confident in your diagnosis of heart failure preserved ejection fraction than reduced ejection fraction. And oftentimes you can delay the care and confirming the diagnosis as you're sorting through those diagnostic tests, particularly if you're talking about primary care, people who aren't specialists and are managing these patients initially before they come to a subspecialist and they've obtained the echocardiogram and had to sort through that.
And to build on that, while we have previously not had as many good therapies for heart failure with preserved ejection fraction, that's actually changing with the development of the SGLT2 inhibitors as well as the GLP-1 inhibitors. That really and aldosterone antagonists have been sort of mainstays of treatment for this, and we're really starting to be able to have things that we can offer patients, and so making that diagnosis is critical. But the other challenge in this is that HFpEF is not one conglomerated diagnosis, it's many, and oftentimes it may not just be that the ventricle is stiff, but in fact actually what we're seeing is the ventricle is stiff because of some underlying disease process such as cardiac amyloidosis or hypertrophic cardiomyopathy or other processes that can ultimately lead to a stiff ventricle, but ultimately the treatment in those cases may be very, very different. And so making sure that we're not only capturing all of the relevant individuals and we're not attributing their symptoms to other causes, but also that we have the right diagnosis and therefore the right treatment set up for our patients is critical.
Yep.
Agreed. And I think earlier diagnosis is even more critical now because we have those treatments available. The burden of heart failure, I think, across the US at least, the last figure I saw was by 2030, the cost of the US healthcare system in terms of heart failure total is going to be about $70 billion by 2030. So it's a huge burden. So earlier diagnosis is even more important in that context, especially as we've got treatments that can impact that number, which is really important.
That's right. And, we want to make sure to also control people's risk factors for that development of disease too. So if you have somebody who you identify early on as potentially being at risk for heart failure, and they happen to have a high blood pressure, for instance, or have poorly controlled diabetes, that just underlines the importance of trying to control some of those risk factors to prevent the progression of the underlying disease.
The response I'll have to that, Jordan, or to add on to that, talking about there are traditional risk factors, right? We know patients who are at risk. There's no standard screening process that we've defined for at-risk individuals, and there's opportunity, particularly I think in the age of AI, for more predictive modeling, right, to determine patients with risk factors, and to do more formative diagnoses and to get therapies on board earlier to prevent that disease burden that is so often it presents itself, as a hospitalization as their first time of getting the formal diagnosis. There's a lot of upstream opportunity with data models that are available to start to hit that diagnosis at the at-risk stage prior to any development of symptomatology.
100%. And all these people, as you mentioned earlier, are going through the Echo Lab. So
Yep.
they're all at the end of the day getting an echo. And I think that, bringing us back to sort of the digital component in this, and this is really critical because we have a captive moment where we can really be able to increase our information at our disposal to make the right diagnosis and make it up front and earlier prior to the onset of disease.
I'm going to add a little question back to you. You made it really clear of the burden that it's bringing towards our healthcare system and the disease setting stage where we're transitioning into seeing more of those patients, and then the complexities of being able to understand it. When we're thinking about that delayed diagnosis, how critical is it for those patients now that we do have the therapies to understand that diagnosis earlier, and kind of what impact will that have not only on that patient care, but also the hospital systems as well?
Jordan, you want to
Yeah, that's a loaded question. There's lots of questions in there. I mean, I can start. I mean, heart failure is if not the most common cause of readmission to the hospital amongst Medicare beneficiaries. So we're talking about a massive problem to the U.S. healthcare system. So even if you make a dent in a small proportion of those who are presenting for care, that has massive ramifications for both those patients and the healthcare system as a whole.
I doing some of my own homework to prepare for this and looking at reminding myself about some of the CMS incentives for reduced hospital readmissions, right? Heart failure has been one of those diagnoses for over a decade, right? So that's just to reduce a readmission because the burden of cost is so high. So if you look at the data that has come out regarding therapies that reduce morbidity, mortality in heart failure, preserved ejection fraction particularly, a lot of that data focuses on heart failure admissions. So you can reduce admission costs and the morbidity that comes with a hospital stay. So earlier diagnoses, earlier treatment reduced admissions to hospitals, and the data has really come to support that.
And even more kind of important, I guess, in really aggressive causes of heart failure, particularly HFpEF, such as cardiac amyloidosis. Some of the therapies that have recently come through for amyloid have been extremely efficacious, not only helping reduce hospitalizations, but also reducing the mortality as well, which has huge benefits for patients, right? And it's also been shown that finding those patients earlier makes therapies more effective. And so it's really important for that specific use case or cause of heart failure.
You couldn't be more right, Ross. I've been in practice for about a decade and seeing the therapies for amyloidosis come to the market and watching the halting of disease progression, right? It's remarkable. I've diagnosed it in a few 90-plus-year-olds, and you see them continue to thrive, relative to their age, compared to what prior to therapies would have been a very, not a very pleasant way to live out your final day. So those early diagnoses for those specific disease cases cannot state the criticality of early recognition, diagnosis, and therapy.
And also, I mean, you can think about it, if they're ultimately not getting diagnosed, but people have symptoms, you're likely to present to the hospital for multiple complaints. You're likely to get a lot of workup. All of that leads to not only cost, but it leads to morbidity and for the patients, and it also leads to a lot of a poor quality of life because people have to be back and forth to the medical center. And so if we have opportunities up front to be able to recognize who in the population actually has HFpEF, and which patients perhaps have shortness of breath, but maybe have another cause for their shortness of breath, as opposed to that, we can not only shorten the time to diagnosis and treatment for those with heart failure with preserved ejection fraction, but also we can shorten the time to make the diagnosis for things that are not heart failure with preserved ejection fraction. Those mimickers that ultimately we see a lot of, but are sometimes attributed to heart failure or treated as heart failure when they're in fact not what's going on. And so there's both sides of the coin. There's misdiagnosis on both fronts, and at the end of the day, what we really need as a system is to have a clear pathway to make the diagnosis and get people on treatment in an expeditious fashion.
Agreed. I think one of the things that's going to expedite this, obviously, is AI. We alluded to it earlier, and I think AI's got a really, really important role to play in the early diagnosis of heart failure. And I think, from my perspective, I'm obviously a developer, but also my company clinically implements AI tools. One of the things to think through, and just to kind of summarize the previous discussion, maybe for other developers out there that are thinking about coming into the space, heart failure serves as an extremely good use case for developing an AI tool for earlier detection. When we think about developing AI tools for earlier detection, we think about kind of this AI diagnostic triangle. The first point of that triangle is, find a disease that is misdiagnosed commonly. The second point of that triangle is that misdiagnosis leads to a big problem, like hospitalizations or mortality. And the third point of that triangle is there has to be a therapy coming through that can help fix that problem. And heart failure and HFpEF specifically, but also cardiac amyloidosis fits that triangle perfectly for where AI can make a massive impact in helping the earlier diagnosis of these diseases. So just something to think about when you're thinking through where AI tools can be beneficial. That's a framework we use internally.
Yeah, and I want to build on that by saying one of the really unique aspects of the Ultromics software is the ability to look at the images itself and pick up on information that may not necessarily be readily available to the clinician at the time. For example, that case that we started with, you wouldn't be able to tell as a clinician necessarily which one has cardiac amyloidosis. And so, but there are some features on the ultrasound that ultimately we may not appreciate as clinicians reading it, but they're present in sort of the data itself. And so things like the number and pattern of grayscale repeats, so that may have something to do with tissue texture, or the movement of part of the mitral valve or one of the valves in the heart that may have to do with relaxation of the heart. And while these are subtle changes and may not be readily picked up on using sort of routine techniques, AI sees this very clearly and can get us closer to the point of making the right diagnosis up front.
Wonderful. As we dive in a little bit deeper into AI and the promise of AI, especially how we can evaluate its use within heart failure as being a great example case, what are some of the barriers that might be in place within healthcare systems as we're looking at integrating such technologies there?
Oh, I'll start with that. There's so many barriers to implementing technology. One is one of the main barriers is certainly a barrier so much as there are so much out there in terms of people claiming to have a product that is effective, right? And so finding those that's that technology, that software that isn't just saying they do something, but showing that, having the data behind them. So that's just that in and of itself is a barrier. The numbers of outreaches that you get from, Ross, you mentioned, developers and startups, it's just nonstop. So finding that partner who's got the clear evidence, the approach, and the data behind it. And then you get into the barriers of working in a health system and the very narrow margins that we all live in. So applying, there'll be a cost to implementing any software to place that in, to get buy-in that this is a good idea, and to get that into your roadmap of integration with softwares and making certain that it's compatible with all of your systems, and that goes on and on and on. That's just the technology implementation part. Then you get into the barriers of adoption, which is a different conversation, when providers just get so tired of piloting, of trying new things and never seeing it come to fruition, or you show them a technology that falls out of their workflow and it makes them less efficient, even though you might think it's the best thing ever. It doesn't work and it doesn't make them more beneficial. I could keep going with more and more barriers, Jordan, but I'll let you add some on there.
I can definitely layer a couple of it. It's unfortunately it's a very challenging area, and I think the key point that you said up front, which is making sure the evidence is there that it works and that it does what you want it to do. And I think that's a key critical component. That's an important part of this process, which is, it's not just about recognizing the disease, it's also about understanding the disease and understanding the disease a bit further. And, when you look at the disease process from the lens of AI, it's one thing if you're, for example, measuring left ventricular volumes or chamber size or ejection fraction, which can be confirmed by a visual assessment. We do routinely as imagers, etc. And so we have a way of sort of checking our work. It's another thing when you're talking about probability of an underlying disease process, where there's really not the same kind of internal check that you can do as a clinician. And so you have to be really confident that what you're getting is not only works across settings, and works in the patient in front of you, but also that it's been appropriately valid, that it leads to good results when you use it in practice. And then you layer on top of that the whole aspect of how you bring this out into practice and pay for it. And not only that, all the regulatory components behind it too. So I think it's a really challenging environment, and people are very skeptical right now of AI. And I want to, at least in some ways, sort of demystify this, that there are, the techniques we use are based on the backbone of core statistics and really have been developed over the course of decades. I mean, neural networks were developed back in the 1970s, 1980s, but the computing power wasn't there to really do this in such a large scale as we have now. And so now we're on a threshold of being able to do more, but there's a lot of skepticism about it. And I think there's skepticism both from the clinicians using this, but also from the administration. And their question is not just, is this going to work well for our patients, but is this ultimately going to be good for our bottom line? And that's a much tougher question to be able to address. Ross is an expert on that one, so I'm going to see if he has some questions.
How long have we got? Look, I think the implementation challenges are manifold, and I think some of what you just heard from Mike and Geordie there is, from kind of the hospital perspective, is how do you find the signal in the noise? You've got hundreds of AI devices thrown at you. Which ones do I know are going to be the best ones, are going to be clinically robust, are going to work in my system, aren't going to go bust in the next year? These are the things you've got to think through from a hospital perspective. But from a developer perspective, I'll give you the other side of the coin here. I think that the few things that, you have to think through to implement, there's kind of four main big clinical implementation things that you have to achieve. I think there's a common misconception, certainly among certain kind of investors that you approach a startup, is once you get FDA clearance, you can then start commercializing and selling. That's so far, while in theory that's true, that's so far from what happens in reality. There's so many other hurdles you have to go through to get to that point. FDA clearance is just the start of the long process it takes to kind of get to commercialization. And FDA clearance can be easy if you're 510K and you're going against someone else, but if you're the first through, you've created the first AI device in your category, you have to do a whole kind of prospective trial, and then that takes years. So FDA clearance is not, it's not as straightforward as some people think. After FDA clearance, you've got the post-market studies. How does your model work in the real world? You've only put it through the controlled studies that the FDA require you to do. How does it hold up in the real world? What happens when you plug into a system where you've never seen that kind of ultrasound data before, where you've never seen that kind of compression ratio from the packs, when you've never had to do a VPN into that specific packs or an HL7 into that specific EHR? How does that all work? So that's your post-market real world studies. Number 3 is health economics. You've got to deliver value to both the provider, but also the payer. Someone's got to be paying for this technology. The provider's not going to adopt it unless they're either getting real value or there's payment there or reimbursement available. So you have to develop a health economics case for both sides. It's got to work on both sides. Fortunately for heart failure, that's one of the rare cases that does work on both sides. And then finally, once you've proven all of that out, it's reimbursement, right? You've got to get the reimbursement code. You've got to get the Cat 3. You start with the Cat 3, you progress to the Cat 1. And reimbursement, once you get there, you think, my goodness, we've done it. We got FDA clearance, we've got the studies, we've got the health economics, we've got the reimbursement, we can start selling. Also may not be the case, because once you get the reimbursement code, you've then got to get payers to actually cover the code. And so you've got to find some hospitals and providers willing to go on the journey with you to figure out what the coverage is doing with your code, figure out if your AI system holds up in their hospital system. So as an AI developer, you really have to find the friendly hospital systems to work through all of these pieces. And only then will you kind of go to the next stage of adoption and start getting kind of scale. But even now, you still get providers, no matter how much validation you do, everyone wants to see it validated in their system, on their data, right? You could do 100 studies, they'll still want to see it on their data. So it's still a barrier to implementation. I've got more, but I'll just pause there and invite others, others to comment.
I wanted to add to that from a provider perspective as well, because I think there's, the reimbursement is massive, and it's huge to be able to have that. But even when you have that, and I think the data suggests that adoption of AI devices is relatively poor to date. I mean, there's a New England Journal AI paper looking at adoption of CPT codes and showing that while there's been 900 or so software as a medical device approvals by the FDA over the course of a couple of the past years, there's very little in terms of actually submitted CPT codes, and it's mostly sort of large academic medical centers. And these are the people who perhaps are willing, as you say, to take the journey with you. But the journey is a journey even within our own medical center. And I can tell you, for our own standpoint, there's the questions about what about security, and if you're sending images outside of the protected health area, what about potential PHI, both in the metadata around the image, but also burnt in images in the DICOM itself, and how do you make sure that's anonymized? And then what about liability concerns? And then there's a second question of, even if all of those are going to come, who's going to do the work? And when you have an IT program, which is you leveraging your IT infrastructure, it's not like people are sitting around with lots of time on their hands and not much to do. I mean, most medical IT people are very, very busy, and so getting even in the queue and then who pays for their time, et cetera, becomes a really an upfront investment. So there may be dividends in the back end, and then there's the question about the dividends. Who do the dividends go to? If you're an Echo Lab, for example, we see our little tiny part of the globe as being our own internal lab. And so when we're thinking about it, it's revenue versus cost. And well, we're paying for AI software. Well, if the hospital is being reimbursed for that, that's great. But how do we make sure that we, as a lab, are being credited with that reimbursement? as opposed to it just falling apart in the general pool. And then from our perspective and from the perspective of our administrators, it just looks like a cost. And so I think there's a lot of considerations at play in integrating it, not the least of which is then despite all that, you get it up and running, people got to use the device and interact with it in sensible ways that you think are reasonable. So I think that's a very short explanation about some of the challenges remaining in the field, but it doesn't detract from the interest in moving forward with this, because it's an important and impactful piece of software and where we need to go in the future.
The one comment that I would make about AI adoption in general in healthcare, this has nothing to do with heart failure or imaging, but if you look at particularly amongst physicians, right? Just look at the ambient scribes that are out there and just the booming use of those, right? And why have they been so successful? They solve a problem that we have, right? They make me more efficient and effective in delivering care. I feel that anyway, right? It's a perception. And it doesn't disrupt what I do every day in a negative way. It might disrupt a little bit, but the disruption is positive. And that's without a lot of all of the other measures of success, right? There's not a lot of financial outcomes that have been shown. I mean, there's some data that's out there from some of those companies, but it is not like it's making a ton of money for organizations, right? But it has been widely adopted across, most of healthcare at this point in time. It's just been incredible to see that. So when you talk about adopting and barriers to adoption, if you can break down those barriers for any provider, you make it work for me, it solves a problem for me. And if it disrupts me, it's in a very positive way. You're going to have more success in getting technology to that front line and really widely adopted. It also, talking a little bit about startups or whatever else, it has to be the design of the application needs to be scalable. And in today's world with AI, it's kind of scalable by definition. So but that's very important. It can't be a niche product for a very specific thing. It really has to be a scalable solution to get some benefit out of it.
And to that end, I just wanted to raise the point that I think both of you touched on earlier, which is that it's really important to get the right problem. There's a lot of temptation because we have the right tools and machinery available to be able to develop AI software that we should, and not all problems necessarily deserve or need AI solutions. And in turn, there are some things that might be able to do and would still be very, very difficult to ultimately get across and adopt. So I think that triangle, having the key components there, that you have a disease that has an adequate treatment yet is under-recognized and under-treated, is a really, really critical and important part of the puzzle, and one that is the bones for a successful strategy. If you don't have that, it's very hard to move forward.
Agreed. That AI diagnostic triangle, I think, is something I thought through during my PhD, actually, when we were first developing tools, and it wasn't a company, it wasn't Ultromics back then. We were actually looking into stress echo and trying to predict coronary artery disease from stress echo, and that served a kind of similar thing in the AI diagnostic triangle. What we didn't predict, which we probably should have done, was that cardiac CT was going to take off and the guidelines were going to change. But that was the initial kind of thesis of the diagnostic triangle. And then we brought it back when we were deciding to kind of target the next disease state, which happened to be HFpEF and amyloidosis. But just coming back to kind of something that Mike said on implementation and kind of what a successful implementation feels like for a clinician. I think a lot of the successful implementations we've done is they sort of feel like we had to make a design choice when we started developing our tools. And the design choice really was one of two things. It was, one, we could put it on-prem, right, on-premise, so no data leaves the institution. Or two, we could host it in the cloud. We decided to go for number two. And back in 2017 or 2018, that was a very unpopular choice with my commercial folk in the company at the time, because no one was doing that, and no one let data leave the institution. But it was important for us because we didn't just see this as a singular model that we were going to deploy on-prem. We wanted the ability to be able to scale our AI and develop many, many models. And as AI got and is getting more powerful, it requires more and more compute, and is quickly becoming unsustainable to put all of these models on premise. And that's the reason we chose a cloud-based deployment. But if you can make that cloud-based deployment seem like it's not cloud-based, seem like it's you have the right IT security in place, but importantly, it feels native to the PACS or the EHR or wherever you're operating from. It just feels like it's there. It doesn't feel like data's moving from one thing to another. That's where our really successful implementations have come from. The cardiologists say, it just feels like it's on my pack. It doesn't feel like the data. Are you sure there's that's the kind of feedback we get. I think that's really important for the success of AI tools, particularly as they become more powerful, and the need to host on the cloud becomes more important.
I want to add to that, which is around the way you've staged the development of your tools, which I thought was very smart. In that, oftentimes we're trying to deal with very rare diseases, and rare diseases can be really tough to predict when you're talking about a general population, because if you trained, for example, your model in an environment where 50% of the people have that rare disease, and you go to an environment where 5% do, you're going to have a lot of false positives, and those false positives are going to erode trust in your ultimately in your AI software. And so the way that Ross and team really approached this, I think, was really smart, which is start with the ground level. What can you do now? And then build upon that. And this sort of gets back to this idea of sort of the Thornbury-Freibeck pyramid, which is a concept raised by two radiologists back in the 1970s, who said that, really, to make the most amount of impact on society, we want to scale things on a broad scale. But to do that, we really need to know the critical things first. Does it work? Does it turn on? Does it do what it says it's going to do? Is it repeatable? Is it reliable? And so those core basics are really the foundation for the things that are built on top of that. And looking at this from an AI trajectory, you started with let's simplify the workflow. Let's automate the ejection fraction and volume quantification and the global longitudinal strain, some of the things we routinely collect as part of an echo. But then let's feed all the echoes through that, and then within those echoes, we're going to then identify the subset of those that ultimately have HFpEF. And within the subset of those that have HFpEF, we're going to identify those who have amyloidosis. And so it's really building on an enriched foundation, which allows you to be more confident in your predictions, but it also allows you to make sure that you're not dealing with a 5% environment. You're dealing with one where in fact, the proportion of disease is much higher.
Yeah, I would say this is a very interesting test you can do as a kind of clinician or provider looking to buy AI tools. This is quite an easy one to see the signal and the noise here. Is have a look how AI tools are both validated and implemented, particularly if you're looking at a rare disease tool. If that rare disease tool was validated in a population where the population was 50% disease, where in actual fact the real prevalence is around 1 to 2%, I would be very cautious about implementing that AI device, because it's just going to generate a ton of false positives. So when you're trying to vet these AI tools, have that at the forefront of your mind, look at the validation data. And I think one of the big kind of pushbacks we've seen from providers and using AI tools is the overcooling of disease. So one way that you can kind of key into that is looking how it was validated, and then secondly, how it was implemented. I mean, as Geordie mentioned, amyloidosis is a really rare, well, not so rare anymore, but it is a disease with about a 1 to 2% prevalence in an echo population, I would estimate. But of HFpEF, of all HFpEF patients, it's about somewhere between 10 to 15% probably. We don't know exactly. but you enrich the population. So when we run our tools, we always run our HFpEF classifier first, and if that's positive, we then run our amyloidosis, and that's ensuring the amyloid classifier is running on an enriched population to prevent the overcalling, and that's a really important way to implement the device. So yeah, just something I wanted to kind of raise there as a way to decipher between the signal and the noise that we discussed earlier.
And I think you're also providing a suite of software then that is around an underlying diagnosis. So not only are you providing help and assistance in making the diagnosis up front, but also, what are some of the causes of it that might be treatable causes within that. And so it helps round out the amount of information that you're providing in a single disease. And I think one of the questions and tensions that you have as an AI developer, I'm not an AI developer myself, this is my presumption, is that you can choose to go narrow, or you could choose to go very broad. That is, you could choose to put all your eggs in a couple of disease buckets and really, really do a good job at trying to make the techniques to identify them as robust as possible. Or you could take the same amount of resources and do many, many different types of diseases, but really do more superficial level screening. And so I think that's an important distinction, because if you're going to deep dive into a disease, you want to make sure up front that you got it right, and that this is the right disease to be able to target, but also that you've developed meaningful ways to be able to interact between the different pieces of the software suite. And what happens when that disease changes over time, or treatment comes out, or whatnot, or the disease prevalence changes. Some of the model is not static, and at the end of the day, updating it routinely is something that can help improve the predictive ability.
Thanks. We've gone down a beautiful journey from understanding the barriers, not only from the development standpoint to the hospital systems to clinical integration, and then rounding out more on that evidence piece. Wanted to kind of take a step forward to kind of explore in the future where we think these technologies will go, and how do we measure success for not only implementing them now, but kind of where we believe that AI will fit into heart failure disease in the future.
Well, I'll start with measurement of success. Depends on where you're looking for success, right? Are you looking for financial outcomes, clinical outcomes, organizational outcomes? But that's kind of how you bucket it. So, financial outcomes. Well, let's start with clinical outcomes, right? Because that's where I'm a cardiologist. I always want to take the best care of my patients. So, do you confirm a diagnosis that you suspect, or rule it out earlier, get them on appropriate guideline-directed medical therapy, and potentially reduce morbidity, mortality, right? That's a definition. That's all measurable success, right? For less common diseases like amyloidosis, same comment, but getting them onto therapies in a more time, or getting referred to someone who manages amyloidosis specifically in a more timely fashion. So time from suspected diagnosis or first presenting symptom to diagnosis to treatment, right? And then looking at overall long-term outcomes. We have databases of all of those patients without the diagnosis, right? Now you can apply potential AI-guided diagnosis and compare that. That's a success rate there. I think all of that also translates then into financial success, right? If you can reduce costs through reduced hospitalization, if there's a CPT code associated with it, there's a financial benefit, right? If you're getting reimbursed for the tests that you're giving, that's the reality of healthcare. You got to get paid for what you do, and if somehow you can improve the efficiency of care, either whether that be through reduced diagnostic testing through test avoidance, that's both cost and efficiency avoidance. You get other patients in for tests you may have referred for. If you can save time or reduce basically use of resources, or to improve your efficiency. So I think that those are some of the high-level success points, and none of those are novel concepts, right? Those are all things that we measure every day in our standard patient population, particularly in our heart failure patient population. I think that's a very quick way to measure success by applying an AI model.
Yeah, I think there's a lot of potential areas in which this can move into, and I would say that increasingly we have an interconnected healthcare system, and multimodality applications and multimodal learning, I think, is really critical, as we as clinicians are never necessarily looking at one specific thing, and even the one specific test may be able to get you close to goal. It's never going to be able to give you the richness that having that suite of information at your disposal there. So, building on things like, can we get the EKG to do more than the EKG does typically? Can we get the echo to do more than the echo does typically? It is going to expand access to sets of tools that we have available, and that's going to allow, I think, for people who otherwise would not have access to those technologies, to really have the state-of-the-art diagnosis at their fingertips, and that's wonderful. But even still, once that's all in place, we still need to study it. We still need to understand, how is this working in our actual care? How is it being adopted? How are people using it? What are people using it for? And are we getting success? Because at the end of the day, success, regardless of how you define it, is got to be something that is measurable and attainable. And you got to have a sense for yourself as well as for your group, what that success means, but know that you're moving in the right direction towards it. And so doing those testing, doing the rigorous evaluations, continuing to work with sites, continuing to work with people involved in the space, and ultimately being at the forefront of these novel technologies, it allows, I think, you to really take a driver's seat in an increasingly rich area where there's lots of opportunity, but a lot more questions than there are answers.
Yeah, I'd agree with that. I think, for us, success is all about patient outcomes. I mean, I think patient outcomes first and foremost. I think there's a big part of it is obviously getting the implementation right and not being a thorn in the side of cardiologists, and making it very seamless, making all the economics work. But for us, it's patient outcomes. I get a thrill out of looking at our service data, seeing how many amyloid patients we've picked up in that day or the past week, knowing the way we've implemented, it's a very good chance they are quite likely amyloid positive patients. We're not overcalling them, and with those kinds of efficacious therapies available, you've got a real chance that you're impacting each and every one of those patients' lives. So for us, it's patient outcomes first and foremost. But I think there is a lot to be said of how do you actually measure it. It's very difficult to do that once you've implemented this clinically, unless you have kind of system-wide IRBs that you implement your technology with. It's very difficult to kind of follow up the patients as a company. So unless you get anecdotal information from the cardiologist that you're working with, it's very difficult to know for that specific day that you've diagnosed 2 amyloid patients what happened to them, unless you have those approvals. So I think I'm a big advocate of prospective trials and RCTs. I think I understand they're difficult to do, and they're time consuming, and they're expensive, and not necessarily first on the mind of AI companies that have a limited budget and are trying to scale and trying to get to FDA clearance. But I do think that they are still kind of the best test we have about demonstrating clinical efficacy. So I definitely think more prospective RCTs in this space, and we have a couple underway ourselves, and we will continue to do them to assess the efficacy of our devices. But yeah, for us, it's patient outcomes for sure.
And I think you touched on something really nicely, Ross, there, which is, you're working with people. It's a partnership, and people are here for the journey, and working with them longitudinally really not only gets to develop sort of relationships, but also you can really understand that you now have a network of people who are committed and have the system. You spent all that effort to integrate things. You now have a tool on site that you can use to be able to really understand what works, what doesn't work in those particular settings, and so keeping that avenue open. And it's not just, here's a product, go have go do what you want with it. There's a ongoing communication and feedback, and how do we learn from this and improve the next iteration of it, I think is a critical part of the process here, because it doesn't, medicine is not static, and neither are the applications of AI within it.
Yeah, it's a really good point, actually, Geordie. I think there is also success. You can measure success with kind of the clinicians you partner with to develop your device and validate your device. I think Geordie and I started working together a few years ago now, and Geordie was able to kind of iterate on our first version of heart failure, and we're now on version 2 and above. And because of the work we did with Geordie, the device is much more robust to kind of real world data. And that's a nice example, because he's here, I'll say it. It was a really nice example of that partnership kind of growing and making the AI device better for kind of real world clinical implementation.
Yeah, and you find stuff. You may find stuff you don't anticipate. I still, to bring a real world anecdote from that collaboration, and that we had sent you, I think, some data on a zoomed out 4-chamber view, and there were a bunch of views where the 4-chamber view was really, really tiny on the screen, and you couldn't see it, and the algorithm was getting sort of weird outputs, and I think you were getting. You recognized that right away and said there's got to be something going on with the underlying algorithms. We looked at it and we found out, in fact, that that normalization of the kind of input to make sure that there's everything is being read by the machine in the same way was of critical importance. And we've even sort of looked at this together to say, in some of the technical improvements actually have real significant improvements in prognostication that occur for patients. So I think that this is a really important area, and keeping that sort of area and interest in investigation and pushing the field forward is going to keep you not only engaged, but also, I think, keep our patients better health.
I think this collaboration has been wonderful, and it tees us up beautifully to wrap back around to that real world case example of that images that we started with at the beginning of the call. So I'll pass it back over to maybe Dr. Upton, and then you can hand it over as well.
Yeah.
Ross, before we do that, so these are very typical images that we see every day, right? I think that's important here. These are echoes that we will see, and I will read one echo as possible amyloidosis, and my partner may disagree with me, or we both might look at it and say, yeah, it could be, right? It's based upon an appearance of the image. That is how on an echo we say that. So this is about as real as it gets from an echo lab standpoint, is looking at pictures like this and determining whether we think it's amyloidosis or not. And I think, if I remember correctly, patient B, it was considered cardiac amyloidosis as a diagnosis, right? And patient A didn't say anything, I believe, if I remember correctly, or maybe hypertrophic cardiomyopathy.
Yeah, so patient A was HCM, originally diagnosed as HCM, and you can understand why, right?
Sure.
I'll let you guys comment on that, but you can understand why that was originally diagnosed as HCM. And then patient B was actually originally diagnosed as, suspect amyloid from the echo, and they got a full amyloidosis workup, including additional diagnostic testing. But it turned out that diagnostic testing was actually negative. And so ultimately they didn't have amyloidosis, so they went through the whole rigmarole without having to. So, and when we sort of ran these through our AI classifier, we found on the patient A that ultimately ended up being positive for amyloidosis, the AI was actually able to detect amyloidosis, picking up on features that are possibly quite hard to see in the image. And then patient B, the AI algorithm also got that right, calling it negative, which would have potentially saved the patient going through all of that rigmarole of getting all of that testing, but also getting worried that they might have this really rare, significant, life-threatening disease as well. So these are two nice cases, because they're not, this is where AI can be potentially beneficial, because no one needs to know what amyloid looks like when you've got the really thick, sparkly myocardium and it's really obvious. But these are two where it's not that, and AI can be helpful to clinicians. But Mia, maybe I'll invite you both to comment on kind of the clinical side of this and what signs you can see from the images.
Yeah, I mean, Mike said it right. I mean, these are the kind of images we get. You would not be able to tell the difference between these, and without other clinical information, I think it would be very, very challenging to, at least based on these images alone, to be able to make that diagnosis. And so, I think there's a lot of concern that I have about anchoring bias amongst physicians. We're used to pattern recognition as imagers, and
Yep.
we see something and we say, okay, that looks like amyloid, therefore I'm going to call this a suspected amyloid. But if it doesn't fit that pattern, then we're not likely to call it. And so as a result, we have these anchors that we put into our mind based on sort of the extremes of these cases where it may be very readily recognizable. But what about everybody else? And I think those people can be overlooked in particular because there's not necessarily another clue to say that there's a particular something abnormal going on. We have this sort of phrase in medicine of when you hear hoofbeats, think horses, not zebras. And I remind people, unless you're in Africa, in which case it's definitely zebras, not horses. But I think the idea is that uncommon presentations of common diseases are more common than common presentations of uncommon diseases. I think I got that right. So we are not necessarily always looking for the things that are uncommon, and so we need helpful tools to be able to help get us there and point in the direction of potentially there being something else that's atypical going on.
Ross, this is a really good question. I think we should probably answer some of these questions, Samantha, because we're getting on time. But how do you handle being robust enough across all of the different acquisition systems? I think that's a really good question. I'm curious to hear your answer.
Yeah, I mean, it's something that's not easy. We from the start try to make sure the technology, a lot of companies get their FDA clearances tied to specific vendors. And in ultrasound, there's kind of four, right? There's Philips, Siemens, GE, Fuji. There's others as well, but they're kind of the big four in the US. We make sure that we have enough of each vendor in the training and validation set so that we prove that the sensitivity and specificity holds up in all the different image types you see, which is particularly important for cardiac amyloidosis when you're looking at when you presumably the AI is looking at things like myocardial texture, brightness, because they vary greatly, particularly between Philips and GE. And so it's really important to have that mixture of the both. And the FDA won't clear it unless you have sample for kind of vendor neutral clearance, unless you have good enough samples of each machine.
Wonderful. Thanks for jumping in there, Dr. Upton, to give a real quick one there. I will pass Dr. Strum. I know you were going to make one quick comment. We have about 60 seconds.
Okay, well, I'm just going to address the last question, which is why not just focus on the upfront picture and the risk factors prevention of these people. And treating the general population is a whole other can of worms, because then if you're moving upstream of these more rare diseases, we don't know which ones of those people are going to end up developing heart failure down the road. And we don't want to necessarily treat everybody because there are risks to treatment. And so I think that's where this can be challenging, and focusing on the right population is critical.
Thanks. Glad we were able to grab a couple of those Q&As right at the end. I know we probably didn't get to do them quite the justice that were the complex questions that came in, but hopefully there was a little bit of help there. Want to thank all my panelists for joining us today. It's been a wonderful discussion. I've really enjoyed our time that we've got to spend together. Really want to thank the audience for coming, having these questions here, diving into the end, staying with us through this journey. I think we hit on several key elements of integrating AI more broadly and using specific case examples through heart failure and specifically HFpEF. It's been wonderful. Thank you so much for all of the commentaries and thoughts, and it will be wonderful to continue these discussions as we move into our next projects here at DIME. So please explore our website. We have some upcoming projects around how we can implement AI for navigating patient care. You're able to navigate through there. And we also recently launched our playbook for implementing AI in healthcare that covers a lot of the comments that have come up and discussion points where we really need to root in and make sure AI is that problem that we're trying to solve for, and it really needs that AI solution, and then how we move through those different elements of integration into healthcare as we discussed here today. So thank you all very much, and we will join you again in a couple of weeks.
Thank you very much.
Thank you.
Thank you all. Cheers.